Okay, good morning. Naririnig ako.
Yes, sir.
Okay, sige. So, as a continuation of our discussion, so today we'll have quantitative platelet disorders. Then we'll have other causes of bleeding, particularly clotting factor deficiencies. And let's see kung pwede nating i-touch pati yung thrombosis. Okay? So for quantitative platelet disorders, so it's either your platelet count is low or your platelet count is high. Okay? O kaya nga quanting, so it talks about numbers of platelets. So last week is about qualitative. So qualitative means it's after with abnormalities affecting the functions of your platelets. So ngayon, it would be quantitative. So obviously, when you say thrombocytopenia, it's whenever your platelet count is low. Thrombocytosis, whenever your platelet count is high. So what would be, sir, the possible consequences? So if the platelet count is low, you expect that your patient may then end up with bleeding. Bakit? Because the moment you have an injury, you cannot easily form that clot and stop the bleeding because platelets are not enough. Okay? Then on the other end, if you have thrombocytosis, ang dami mo namang masyadong platelets. Okay? So having excessive amount of platelets may then end up with unwanted formation of clot. So as I've said last week, di ba, pag meron kang problem with hemostasis, so it's either you end up with bleeding or you end up with thrombosis. So in thrombocytopenia cases, this is the one that usually ends up with bleeding, and the other one is the one that usually ends up with thrombosis. So when it comes to thrombocytopenia, we can then attribute this thing into three different factors. Okay, pag sinabi nating thrombocytopenia, you're dealing with thrombocytopenia, number one, it could be with decreased production of your RBCs, of your platelets rather. Number two, there could be destruction of your platelets. And number three, there is abnormal distribution of your platelets. So it's quite basic. So when you say decreased production, basically the problem lies within your bone marrow, right? When you say destruction, from the term itself, there's something that destroys your platelets. And when you say abnormal distribution, it's a problem with the allocation of platelets in your body. Or normally, out of all the produced platelets from the bone marrow, normally, how many circulates in the blood? How many percent usually circulates in the blood? 70%. Right? Nasaan yung 30%?
Spleen po.
It's within your spleen. Tama? It is sequestered in the spleen. So when you say abnormal distribution, it's whenever your spleen is enlarged. So instead of 30%, or let's say for example, since your spleen is already enlarged, let's say for example, your spleen now sequesters 60% of your platelets. So ilan na lang ang natira sa blood? Sir, mga 40% na lang. So with that note, you expect that as you count the platelets, automatic, it will be decreased. Do you follow?
Yes po.
Maliwanag ba? Okay, so when it comes to decreased production, we have the following causes. So number one, aplastic anemia. Ito, as what you've learned in your Hemo 1 class, diba? Aplastic anemia is whenever your bone marrow is totally down. There's total suppression of your bone marrow. That is usually caused by, let's say, you are infected with certain virus like parvovirus B19, you are exposed to radiation, you are undergoing chemotherapy, you're taking chloramphenicol as an antibiotic. So pag sinabi nating aplastic anemia, remember, all your cell counts are low. RBC count, WBC count, platelet count, all of them are low because your bone marrow is totally down. Okay? Because of those reasons. Okay? Then, pag sinabi nating suppression of megakaryocytes, selective suppression of megakaryocyte, from the term itself, you are suppressing megakaryocyte, thus resulting to a decreased release of platelets from the bone marrow. And as to studies, selective suppression of megakaryocyte has been associated with the administration of chlorothiazides. Itong drug na to. So it may then result to suppression or damage of your megakaryocytes within your bone marrow. And remember, di ba, kung masisira ang bone marrow natin, expect that one of the first things that can be damaged will be your megakaryocyte. Bakit? Kasi sir, within the bone marrow, megakaryocytes are the largest cells in the bone marrow. Right? So, mas prone sila or mas madali silang masira. Kasi nga, laki-laki nila. Okay? Then when you say TAR syndrome, o sulat nyo na lang, that is thrombocytopenia with absent radius. Again, that is thrombocytopenia with absent radius. So it's basically a problem of megakaryocyte production. Okay? There is an abnormal production of megakaryocytes within your bone marrow, especially among newborns. So it could be attributed because of certain genetic abnormalities, or it could be because of certain nutritional deficiencies that then leads to the production of abnormal megakaryocytes. And remember, saan ba nanggagaling ang platelets natin? Sa megakaryocytes, right? So any problems or any anomalies affecting your megakaryocytes automatically affects platelet production, thus resulting to thrombocytopenia. Okay? Then, with the next one, pag sinabi nating myelophthisic process, it's like, imagine this is your bone marrow. There are space-occupying lesions. Parang merong mga sugat or merong mga scars yung bone marrow natin. Scars or injuries because of tumors, because of fibrosis, or because of any unwanted disease affecting your bone marrow. So because of these space lesions, there'll be no more enough space for your megakaryocytes. Sooner or later, myelophthisic process may even lead to aplastic anemia. If you are not able to treat it, let's say meron ng tumor within the bone marrow and kumalat na yung tumor, later on, it might then totally affect the production of all blood cells. Okay? And then lastly, when you say ineffective, it's whenever your marrow can produce cells, but the problem is the ones you are producing are abnormal cells. And remember this, if one cell production is ineffective, it means to say that other cell production will be ineffective too. Sir, bakit? Kasi remember, halos pare-pareho lang naman sila ng nutritional requirements as they mature within the bone marrow. Red cells, white cells, megakaryocytes, if you will go with the maturation and nutritional requirements, they may then require the same things. O for example, red cells maturation, WBC maturation, and megakaryocyte maturation will all require B12 and folic acid. So, if one is ineffective, di ba, usually, sir, I associate vitamin B12 deficiency and folic acid deficiency with megaloblastic anemia. Hopefully, you can still remember it. Megaloblastic anemia. So, if B12 and folic acid are deficient, it does not only affect red cells. It also affects white cells and platelets. Kasi they also need this. Kasi yung B12 na yan and folic acid na yan are needed for nuclear metabolism of your cells. Immature RBCs, yes, they contain nucleus. Mga white cells natin, definitely they contain nucleus. Megakaryocytes natin, definitely they contain nucleus. So all of them will require the same set of minerals, same set of nutrients. So when you say ineffective thrombopoiesis, expect that other cell production will be ineffective too. And when you say ineffective, again, your marrow can produce cells, but the ones you are producing are immature cells. The ones you produce are abnormal cells. Is that clear?
Yes po.
Yes po.
So again, pag sinabi nating thrombocytopenia, it's whenever when you say decreased production rather, it's whenever you have a problem within your bone marrow. Okay? You have a problem with the marrow that results to a decreased production of platelets in your body. Okay? And then second reason for having thrombocytopenia is destruction. There is something that destroys your platelets. And destruction of platelets could either be immune or non-immune. When you say immune, it has something to do with antibodies. Okay? And these antibodies here could be autoantibody or alloantibody. Di ba? Pag sinabi nating autoantibody, you produce an antibody against your own cells. Right? Alloantibody means the antibody that destroys your cells is from another individual, from other person. Say for example, transfusion. Right? So kunyari, sinarina ka ng dugo, platelet, blood transfusion. You have this purpura or you have this refractoriness even after transfusing blood, possibly because of antibodies. So it's either the transfused blood contains antibodies against your platelets or ikaw mismo, you have an antibody against the transfused cells. Kasi it could go either way. Pwedeng ikaw yung may problem or pwedeng yung sinalin sa yung blood yung merong problem. Did you get that? Maliwanag ba yun?
Yes po.
Sir.
Yes,
Okay,
and
sir.
with this neonatal isoimmune thrombocytopenia, it's some sort of transplacental passage of mother's antibody going or against the baby's platelets. Yan, habang buntis. Especially if you have IgG antibodies. Kasi IgG antibodies are the ones that can cross the placenta, right? So, when you say neonatal isoimmune thrombocytopenia, it's whenever the mother contains IgG antibodies that can react against the baby's platelets. Okay? Kaya, yung antibody from the mother will then destroy the baby's platelets. Okay? And then ITP here is referring to immune thrombocytopenic purpura. Okay? Immune. It usually occurs after viral infections. At most cases, forming antibodies at most cases occurs after viral infections. You may then develop certain antibodies because of that viral infection. So, for example, ngayon sa COVID, you'll never know. If you have been infected with the virus, you'll never know. You might then form antibodies. We can never tell. Right? So after viral infection, you may have that antibody that may destroy your cells, including your platelets. Okay? And then, secondary immune thrombocytopenia occurs as a result of underlying diseases. Kasi may mga ibang sakit na pwedeng ang isa sa mga side effect nila is masira yung mga cells natin like platelets. So, for example, during in cases of SLE, HIV, leukemia, sometimes may then destroy your platelets. Okay? So when you say immune, it has something to do with your antibodies that can destroy your platelets. But when you say non-immune, so it has nothing to do with your antibodies. These are more of external factors that may destroy your platelets. And one common example here that destroy your platelets would be DIC, disseminated intravascular coagulopathy. Disseminated meaning it's all over your body, intravascular meaning it's within your blood vessels, coagulopathy means you have activated coagulation mechanism. It's like in DIC, it's hypercoagulation and excessive fibrinolysis. Oh, imagine, in DIC there is hypercoagulation. Gawa ka ng clot. Yung platelets ba part ng clot? Yes or no?
Yes po. Yes.
Yes. Tama? They are part of the clot. And in DIC, you keep on producing clot even if you don't need them. Or for the nth time, when do we form a clot? Kailan tayo nagpo-form ng clot?
Pag may injury.
Pag may injury po.
If
Pag
there's an
merong
injury po.
right? Pag meron tayong bleeding, doon ka lang naman magpo-form ng clot dapat. Right? But in DIC, sir, I don't have an injury. I don't have bleeding, sir. So why did I form a clot? It's because of an abnormal activation of coagulation mechanism. And remember, DIC is always a complication of an underlying disease. Meron kang sakit that develops to DIC. For example, leukemia. Yan, M3 leukemia, for example. You have that disease, that's why it then developed to DIC. Gawa ka ng clot kahit hindi mo naman kailangan. And the thing with DIC is, yes, you keep on forming clot, but at the same time, you keep on lysing them. You keep on destroying them. So if you remove the clot, if you lyse the clot, you're also lysing your platelets. You are consuming platelets and you are lysing your platelets. The worst thing here is, sir, ginamit ko na yung platelets, ginamit ko na rin yung clotting factors. The moment you have an actual injury, you cannot then form a clot. Bakit? Ubus na yung platelets mo. Ubus na yung clotting factors mo. You cannot easily form clots. Meron ka ng totoong injury, meron ka ng totoong bleeding, but you cannot form clot because your platelets and clotting factors were already consumed. And what makes it even more deadly is that if you activate coagulation mechanism and fibrinolytic mechanism, if you will recall it, you also activate kinins. Okay? And if you activate kinins, di ba yung mga yung mga prekallikrein, di ba plasmin natin, if you activate them, you will activate kinin resulting to increase vascular permeability. Imagine, within your blood vessels, it's permeable. So cells inside, particularly RBC, can easily leave your blood vessels. Lalabas yung mga RBC mo. And if red cells leave your vessels, you will then suffer the consequences of decreased delivery of oxygen into your tissues. Kaya in DIC, ang nakakatakot dyan is that later on, it may then lead to shock or hypotension. Because of that, decreased delivery of oxygen onto your tissues that can even lead to death. Okay? So aside from bleeding, that's the common complication, patients with DIC might also end up with hypotension or even shock. Maliwanag ba?
Po, sir.
Yes po.
Yes po, sir. Okay, then another cause of non-immune destruction of platelets may include hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. Both ways, pareho lang naman sila ng course. In hemolytic uremic syndrome, you form unwanted clots within your kidneys. Thrombotic thrombocytopenic purpura, you form clots all over your body, unwanted clots. So just imagine, ito yung blood vessel natin. And within your vessel, there are lots of clots. So if there's clot, again, part of it will be platelets, right? And if there are clots, as cells like RBCs, platelets, pass on through those clot. Kunyari, dumaan sila, napadaan sila dun sa clot. They will then be damaged. They may then be destroyed. Kaya in cases of hemolytic uremic syndrome or TTP, expect that there will be anemia because you may destroy your RBCs. And because of that anemia, it will then stimulate your bone marrow to produce more cells, thus resulting to increase reticulocyte count. There will be decreased platelets because you consume platelets, and possibly it may then destroy your platelets. And because of that hemolysis on your red cells, hemoglobin will increase, bababa si heptoglobin, tataas si bilirubin natin because your red cells have already been lysed. So pag sinabi nating non-immune platelet destruction, again, it has nothing to do with antibodies. These are more external factors that may then destroy your platelets. And as mentioned a while ago, platelet count may be decreased because of abnormal distribution, especially whenever your spleen is enlarged. Okay? And then lastly, for quantitative platelet disorder is whenever your count is high. And usually, tumataas naman ang platelet count natin abnormally if there is excessive production of cells within your bone marrow. You keep on producing cells even if you don't need them. Excuse lang ha, excuse lang. Okay, so going back. So in thrombocytosis, so it's whenever the platelet count is high, right? And again, it could be associated with abnormal production of cells from your bone marrow. So if there is, let's say, leukemia within the bone marrow, then expect that pwedeng yung platelet count natin is elevated. So example of which would be, ayan, these are form of leukemia, right? Polycythemia vera, where all cell counts are elevated, as well as essential thrombocythemia or essential thrombocytosis. So these are forms of, if you will recall it, these are forms of chronic myelogenous leukemia. Tama? Kasi 'di ba in leukemia, it's characterized by increased or excessive production of blood cells. Okay? And lastly, thrombocytosis may also occur temporarily or transient. Ibig sabihin, it occurs whenever you need platelets. Kailan ba natin, sir, kailangan ng platelets? If there is an injury. Right? So let's say you have an injury, a quite severe injury causing bleeding. So the initial response of our body is magparami ng platelets. Okay? The initial response is to produce more platelets. But then, if the injury and bleeding will not be stopped from elevated platelets, later on, bababa yan bigla. Okay? O for example, na-aksidente ka or let's say nasaksak or nabaril yung pasyente, in the beginning of the bleeding, expect na yung platelet count mo is tataas. Kasi that's the initial response of our body. But later on, it may suddenly fall because your body can no longer take that bleeding. Kaya in such injuries, yung mga masyado ng malala, na baril or nasaksak in vital organs, then there is a need to undergo surgery. So you can then immediately stop the bleeding. Kaya tinawag nating transient or temporary because in the beginning, it may go up, but later on, once it is not managed, it may then suddenly drop. So quantitatively, again, problems with platelets could just either be the count is elevated or the count is decreased. And again, when the count is high, most of the time, or most likely rather, it will then end up with thrombosis. And if the count is low, it will then end up with bleeding. Is that clear so far?
Yes po.
Yes po, sir.
Yes po.
Okay. So, as a continuation with bleeding, so other causes of bleeding definitely will include clotting factor deficiencies. Diba? If you have deficiencies in one or more than one factors, then expect that there will be bleeding. Kasi the moment you have an injury, you cannot then easily form that clot because you don't have enough of these clotting factors. And again, if you will then be after with bleeding, remember, you should not rely your diagnosis with clinical presentation of the patient alone. Kasi tandaan, kapag bleeding, the signs and symptoms or the clinical presentation may just be the same. Okay? If you are bleeding because of platelets, the other is bleeding because of factor 1 problem, the other is bleeding because of factor 2 problem. Basically, if you will check the signs and symptoms, it may just be the same. Pare-pareho lang sila. Okay? So, kung magda-diagnose ka ng sakit, especially bleeding, might as well go with laboratory tests that will further help you confirm what is the specific cause of bleeding. Because by identifying the cause of bleeding will then help you to properly treat and manage your patient. O kasi for example, let's say, your patient is bleeding because of platelets. Okay? Pero ang binibigay mo na gamot or na intervention, let's say, is address to answer problems with, for example, factor 8. Platelet yung problem mo, pero bigay ka ng factor 8. So, still, you will not be able to stop the bleeding of your patient. Right? Hopefully, you're getting the point. Okay? So, by doing laboratory test, you can then further identify what would be the specific cause of bleeding so you can then appropriately manage and treat your patients. Okay? So with the treatment, usually for clotting factor deficiencies, remember, it's blood transfusion. It's by transfusing FFP. But take note, patients with bleeding, especially with clotting factor deficiencies, should only be treated if they are bleeding. Kung wala naman silang bleeding, huwag mo salinan ng dugo. You get that? Kung may bleeding, that's the time that you really need to transfuse the patient with blood. Okay? So before we go on with the next, what I would like to highlight here would be in clotting factor deficiencies, you need to give importance more with the laboratory tests. Di ba meron tayong clotting time, meron tayong PT, meron tayong APTT, right? So this is for extrinsic. Hopefully you can remember. This is for intrinsic. Then you have Steven time. Steven time para kay common pathway. You have, para saan si thrombin time? Specifically, para saan si thrombin time natin?
Extrinsic.
Specifically, para saan si thrombin time? Factor, anong factor number?
7.
Nakalimutan na. Factor number 1. Right? Thrombin time is specifically designed for fibrinogen, right? Oh, how about Dackert's test? Para saan uli si Dackert's test? Uy,
13.
para kay factor number 13. Right? So, with this, let's then discuss these disorders based on these laboratory tests. So let's say you have a problem with factor 1. You have a problem or deficiencies with fibrinogen. So since it's all about clotting factors, definitely, mga clotting time nila always prolong. Okay? Para hindi tayo paulit-ulit. Lahat ng clotting time nila is prolonged because it deals with clotting factors, right? And since factor 1 is under common pathway, what will you expect to the PT and APTT of your patient? Ano mangyayari sa PT and APTT niya? Parehong prolong. Kasi if it's common, both of them will be elevated, right? Steven time is for common pathway, so it's elevated. Thrombin time is for factor 1, so it's elevated. But Dackert's test will still be normal. Right? Here comes the confusing part. You have here factor 5, factor 10, lahat sila common pathway, right? And factor 13. So if 5 and 10 are with common pathway also, expect that clotting time, PT, APTT, Steven time will just be the same with factor 1. Except that thrombin time for them will still be normal. Kasi its thrombin time is only for factor 13. Factor 1 rather. Do you get that?
Yes po,
Let's
sir.
go.
Yes po,
O
sir.
tanong, paano ko malalaman if it's factor 5 or factor 10? Pareho sila ng resulta. Right? So how will I know if it's factor 5 or factor 10? Uy,
Mixing studies.
you go with mixing studies. Tama? You go with substitution studies. Excuse lang. Okay. Sorry, ah. Then, moving on with factor 13. So again, since factor 13 is needed for the stabilization of the clot, and in coagulation test, di ba, ang gusto lang naman natin, our endpoint is to form clot, right? So expect that all these tests would be normal. Definitely, except for your Dackett's test. Kasi lahat ng mga yan, basta makagawa ka ng clot, right? And in factor 13 deficiency, remember, you can still form a clot. The only problem is, the clot you form is unstable. Kaya if you test it, yung mga PT mo, APTT mo, all of them will still be normal. Problema lang is, the clot is unstable. Okay? O how about if you have factor 7 deficiency? Sa kanilang lahat, saan lang siya magiging abnormal? If 7 is deficient.
PT.
So, except for clotting time, ha? Definitely. Prolong yung mga clotting time. Okay? But with 7, saan siya magiging abnormal? It would be with PT. Kasi PT is for extrinsic pathway. The rest, yan, mga normal naman yan. Right? And then with common pathway, with intrinsic pathway rather. So you have factor 8, you have factor 9, you have factor 11, si 12, huwag nyo nang intindihin si 12. Okay? Kasi if 12 is missing, remember, the patient does not manifest bleeding. Okay? So with 8, 9, and 11, expect that pare-pareho sila ng resulta. So normal with PT, prolonged clotting time, prolonged APTT, normal Stephen time, thrombin time, and Dackett's test. All of them will just give you the same set of results. Again, to differentiate them, you go with mixing studies. And this time, you can now go with clinical presentation. 8, 9, and 11 are your hemophilia. Hemophilia A for 8, hemophilia B for 9, and hemophilia C for 11. So the bleeding severity depends now on the type of hemophilia. The most severe is 8, followed by 9, followed by 11. Okay? And more so, sa mga patients with hemophilia A, there may also be hemarthrosis or bleeding on your joints. Kaya we consider it na kumbaga mas severe, okay, compared with other forms of hemophilia. Okay? So in clotting factor deficiencies, remember, yun yung kailangan nating mas i-highlight. Ayan, kaya sa exam ninyo, ayan, expect na magbibigay uli ako ng mixing studies, pero this time, ang ibibigay ko na is the name of the disease. Okay? So just to add a bit more of information about this factor deficiency, so with factor 1, it could be because of increased consumption, gawa ng clot, that's why your factor 1 becomes deficient. Ayan, especially, ayan, as mentioned a while ago, pag meron ka ng DIC, you keep on forming clot even if you don't need them. So the moment you need these factors, they are no longer available. They are no longer enough. Okay? So with factor 1 problems, it could be of 3 things. Fibrinogenemia, totally halos wala na. Hypofibrinogenemia, you have deficiencies. And this fibrinogenemia, you have normal concentration of fibrinogen, but the structure and function is abnormal. So normally, fibrinogen levels would be around 200 to 400 milligrams per DL. So if the value falls, let's say 100, nandun ka na sa hypo. Mas bumaba pa sa 100, you may then fall under fibrinogenemia. Okay? Then with factor 2 deficiency, dagdag ko lang, factor 2 deficiency, this is prothrombin. Right? Factor 2 is prothrombin. Tama? And you know how important prothrombin is. Without prothrombin, you will not form thrombin. And without thrombin, you will not convert fibrinogen to become fibrin. So in short, pag wala yung thrombin na yan, you don't form clots. You don't form that clot necessary to stop the bleeding. Okay? Then, i-jump ko lang ha kasi naputol eh. With factor 5 deficiency, you call it as Oren's disease or sometimes known as parahemophilia. Kasi both factor 5 and 8 are labile factors, right? Sometimes, clotting factor deficiency could just be a technical error. Sometimes. Diba? 5 and 8 are labile factors, so they easily deteriorate. So if you did not handle the specimen properly, you did not process the specimen properly, so pwedeng mawala si 5 at saka si 8. And sometimes, it could be the reason on why your patient is diagnosed with hemophilia or with factor 5 deficiency. So you always need to be careful in handling specimen for coagulation. Kasi baka wala naman palang factor 5 or 8 deficiency yung pasyente, pero he was diagnosed with such because the medtech did not handle the specimen properly. Okay? Then again, you have factor 7 deficiency, and usually in factor 7 deficiency, it is more prominent if there is liver problems, if there would be liver disease. Okay? Bakit? Kasi sa liver, di ba, clotting factors are synthesized by your liver. So any problems affecting your liver will then result to deficiencies in clotting factor production. And as what you know, 7 is the most stable clotting factor. So kapag 7 na yung nawala, you can attribute this to a severe damage on your liver. Okay? And then with factor 8, ayan, as I've said, it is hemophilia A. Among the types of hemophilia, this is the most severe. You call it sometimes as Royal's disease because the royal family have this one. And take note that hemophilia A is an X-linked disorder. When you say X-link, males will then manifest the disease, whereas females will serve as carriers. Okay? Then, to treat patients with hemophilia, sometimes you can give the treatments given to those patients with von Willebrand's disease. Ito yung mga binibigay doon, right? Especially this is one. Anong kinalaman niya, sir? It's because von Willebrand factor makes sure that your factor 8 is stable. So you can then stimulate your endothelial cells to release von Willebrand factor, hoping that it will stabilize your factor number 8. Okay? Then a milder form of hemophilia is factor 9 deficiency, or what you call as Christmas disease, because 9 is Christmas factor, and the mildest form is factor 11. Itong si factor 11, and dagdag nyo, aside from being called as hemophilia C, it is also known as Rosenthal's disease. And under intrinsic pathway, factor 11 deficiency is the first clotting factor deficiency discovered. Under intrinsic pathway, ha? The first factor, the first inherited disorder under intrinsic pathway. Okay? Then again, when it comes to factor 12 deficiency, ulitin ko, it's not a problem basically kasi if you have 12 deficiency, your patient will not manifest bleeding. Okay? Kasi you have other ways on how you can activate clots. Kung 12 lang ang problema, it's not a major concern. Kasi your patient will not manifest any forms of bleeding. Okay? Then with factor 13, since the clot you form is unstable, in factor 13 deficiency, it may then lead to prolonged wound healing. Ang tagal mo naman ngayong mag-heal. Kasi yes, you form clot, but since it is unstable, you easily destroy that clot. So wala rin nangyayari. Okay? Then, other causes of bleeding will include the following. So you have liver diseases, especially because liver is the one that produces clotting factors. Kaya yung mga lab test na binanggit natin kanina, PT, APTT, may also be elevated. In vitamin K deficiency, it can also lead to bleeding because there are clotting factors dependent with vitamin K. Ano uli yung tawag sa group na yon that is vitamin K dependent?
Prothrombin group po.
Prothrombin group. And what are those clotting factors that are dependent with vitamin K?
2, 7,
2,
9,
7, 9, and 10. Diba? So without vitamin K, kahit ang dami-dami mong 2, 7, 9, and 10, without vitamin K, these factors will not interact with the others. Right? And sometimes, you can have bleeding because of circulating anticoagulants or circulating inhibitors, particularly lupus anticoagulant. Yan, if you recall it, lupus anticoagulant inhibits phospholipid. Phospholipid, which is greatly needed in the formation of clot, right? And this is an antibody, by the way, si lupus anticoagulant. It could be an IgM, it could be an IgA, or worst is, it could be an IgG antibody. Kasi pag IgG yan, it can then now cross the placenta. Right? And then FDPs here, if you recall it, sir, these are products of fibrinolysis. So sir, bakit ako magkakaroon ng bleeding because of FDPs? Because FDPs here prevents the polymerization of your clot. O let's say, sir, meron akong clot, I destroyed that clot, so I formed FDP. O, meron kang FDP. Problem is, if you will form another clot, you cannot stabilize them because FDPs here inhibits the polymerization of that clot. Okay? So yung clot mo, hindi nagiging stable. It's because it was inhibited by FDPs. Okay? And then, transfusion of blood, massive transfusion. It's not just a single transfusion, ha? Massive transfusion. So, ang daming sinalin sa iyo na blood. And because of that, you have also received a lot of anticoagulants. Kasi may mga anticoagulant yung blood bags natin, right? So, that can then prevent you from forming clots. And as what we have said a while ago in DIC, you consume platelets and you consume clotting factors. That's why there may then be deficiencies in clotting factors resulting to bleeding. And remember, kapag DIC, lahat ng test mo for coagulation will be elevated. Kasi you don't have enough clotting factors, you don't have enough platelets to allow you to form a clot. Is that clear?
Yes po.
Yes po.
Okay, then lastly, ayan, sama ko na to ha, para wala na tayong maiwan na topic. Then lastly, so kung meron kayong bleeding, meron din tayong thrombosis. If bleeding is associated with hypocoagulability, meaning hindi ka makagawa ng clot, in thrombotic naman, you keep on forming clots. If in bleeding, you have hemophilia, you love bleeding. In thrombotic disorders, you have thrombophilia. You keep on forming clots. Okay? And the clot you form there depends, the name or the complications of that clot depends on its location. So, pwedeng sa arteries, pwede rin sa veins, right? It depends on the location. And what makes it deadly is that if the clot you form is on the vital vessels or vital organs of your body. Let's say, ang clot mo is napunta ron sa brain mo. Yung clot mo is meron doon sa cardiovascular system mo. Having that unwanted clot may easily lead to death. Yan, for all you know, yung myocardial infarction or atake sa puso, even stroke is most likely because of the clots, unwanted clots that you have formed. That's why, for patients, ayan, if you know someone, for patients who had heart attack, for patients who suffered from stroke, isa sa mga gamot na binibigay sa kanila or maintenance medicine that they have are anticoagulants. Isa yun. So you can prevent them from forming clots. Kasi if you have already suffered from stroke or heart attack, the last thing you want to have again is unwanted clots. So to prevent you from forming this unwanted clot, doctors will then give you anticoagulants. Take note just to make it clear lang pala, when it comes to those drugs or treatments, anticoagulant is different from thrombolytics. Magkaiba yon ha. Thrombolytic, you have the clot, the patient had the clot, you will lyse it, you will destroy it. Anticoagulant, wala ka pang clot o wala ka pang injury, so you will prevent the formation of clot. On this case, you are destroying the clot your patient formed. On this case, you want to prevent them from forming clots. Nakuha ba yun?
Yes,
Opo,
sir.
sir.
Okay, and then to understand better and easier the concept of thrombosis, balikan lang natin ng konti yung normal concept of hemostasis. Okay? You have that injury, you bleed, so you activated clotting factors, right? You activated platelets so that you can form a clot. Let's recall it. After you form that clot, after the bleeding has stopped, what do we do with clotting factors and even with platelets? Tapos na yung trabaho. So what do we do with them? Uy! Anong ginagawa natin sa kanila?
Lies po.
We're not talking about clot. What do you do with clotting factors? What do you do with platelets after you form that clot? With the clot, you lyse them. But how about those clotting factors? You then inhibit them. Tama? You deactivate them. Right? And how do we deactivate or how do we inhibit them? It's because we have a lot of regulatory proteins. Right? In short, we call them as inhibitors. Tama? So you can inhibit them. So when it comes to thrombosis, most of them are caused by deficiencies with your inhibitors. You don't have these inhibitors. That's why clotting factors and platelets remained active. So if these factors and platelets remained active, anong gagawin nila? They will just continuously form clots. Okay? So it's important na, sir, I have clotting factors, I have platelets, but it's also equally important that you have these inhibitors so to make sure that you don't form unwanted clots. So ang problema natin kay thrombosis is that you don't have these inhibitors. That's why your clotting factors and platelets remained active. And if they remained active, you will just continuously form unwanted clots. Say for example with antithrombin. Okay? Diba? So what you know, antithrombin rather, is an important protein to inhibit thrombin. Kasi thrombin is the only enzyme that converts fibrinogen to fibrin. So kung wala kang thrombin, hindi ka na makakapag-form ng clot. And that's the job of antithrombin. So imagine, if you don't have antithrombin, it makes your thrombin free. Gala lang ng gala si thrombin. And if thrombin remains there, it will just continuously convert more fibrinogen to become fibrin. Did you get that?
Yes, po.
Yes po, sir.
Or if you recall it, what are those clotting factors inhibited by protein C and protein S?
5
5 and 8.
5 and 8. So both of them, if protein S and protein C are deficient, expect that 5 and 8 will remain active. And again, you know the drill. Diba? It's a domino effect. If one factor is active, it will activate another and so on and so forth until you form a clot. So baliktarin natin, kung wala si protein C and si protein S, factors 5 and 8 will remain active, thus resulting to more and more clots. Okay? Then, with another cause of thrombosis here, it's now associated with amino acids. Homocysteine, to be specific. Homocysteine sometimes may accumulate in your body because of enzyme deficiency. You fail to metabolize homocysteine, so that's why they accumulate. Ang problem is, once they accumulate, they may be deposited on your blood vessel, resulting to injuries. Anong mangyayari? Pag merong injury sa vessel natin, anong ginagawa natin? Pag may injury sa vessel natin, what do we do?
Produce po yung katawan ng...
We form clots, right? Because of that injury, there will be bleeding, right? So what we do is we form clot. So if you have these enzyme deficiencies here, you can expect that homocysteine will accumulate, and this homocysteine may then result to unwanted damage on your vessels, leading to the formation of unwanted clots. Kaya ka ngayon nagkakaroon ng thrombosis. And remember, para hindi tayo paulit-ulit, if there's a clot within your vessel, it then blocks the delivery of nutrients. Imagine, if this is your blood vessel and there's clot, it blocks the flow of blood. It blocks the delivery of nutrients to your tissues. Right? The next one is an inherited disease. You call it prothrombin 20210 mutation. So, in this case, just to make it straightforward lang, direct to the point. In prothrombin 20210 mutation, your prothrombin production is too much. Sobrang dami mong prothrombin. You exceed more than 130%. And again, it will be a domino effect. More prothrombin will mean more thrombin. Right? And more thrombin will mean more fibrinogen converted to fibrin. Did you get that?
Yes, po.
Maliwanag ba?
Yes, sir.
Kaya, in this type of mutation or inherited disease, the patient then is forming unwanted and unnecessary clots. And another common inherited disorder leading to thrombosis is factor 5 Leiden. So with factor 5 Leiden, factor 5 here resists inhibition by protein C. Di ba si protein C, as what you've said a while ago, inhibits factor 5, right? So in factor 5 Leiden, parang let's just say, lumalayo si factor 5 with protein C. Okay? It inhibits protein C resistance. Nandiyan na si protein C, lumalayo pa si factor 5. So if 5 remains active, again, it will just continuously activate other factors until you form a clot. Okay? Then a while ago, we've said that, sir, lupus anticoagulant leads to bleeding. Ngayon, lupus anticoagulant can also lead to thrombosis because lupus anticoagulant, aside from inhibiting phospholipids, it can also inhibit specifically prostacyclin. And if you may recall it, prostacyclin prevents you from forming a clot. So baliktarin natin, kung wala kang prostacyclin, you can now easily form a clot. And that clot could be unwanted. That clot could be unnecessary. Right? So pag may lupus anticoagulant, parang either pwedeng meron kang bleeding or pwedeng meron kang thrombosis. Okay? And then as what you've learned, it's quite basic. Si heparin natin, heparin is a naturally occurring anticoagulant, right? And inside the body, heparin makes your antithrombin stronger. Right? So kung wala si heparin natin, it's possible that your antithrombin becomes weak. And weak antithrombin will mean inability to easily inhibit thrombin. Making your thrombin now free, and making thrombin easily converts fibrinogen to fibrin. Kasi nga mahina na si antithrombin. Okay? Then, thrombomodulin here, if you recall it also inhibits thrombin. And thrombomodulin, remember, activates protein C and protein S. So with the course of the disease, if thrombomodulin is deficient, you will not be able to inhibit partly your thrombin. And more so, if thrombomodulin is deficient, wala si protein C and si protein S. You cannot activate them. So if you cannot activate protein C and protein S, again, what are those two factors that will remain active pag wala si protein C and protein S?
5 and 8.
5 and 8. And then lastly, I think it's quite basic. If your liver will not produce enough plasminogen, you will not have enough plasmin. Domino effect. And plasmin, as what you know, is the one that destroys your clot. Right? So kung wala si plasminogen, wala si plasmin, hindi mo malalize yung clot. So the clot will stay and will remain within your blood vessels. So in cases of thrombosis, ayan, meron ng risk yung patient natin to form clot. So to prevent the formation of unwanted clots, your patients may then be given anticoagulants. And the initial anticoagulant to be given among those patients at risk for thrombosis is heparin. Kasi heparin is naturally occurring, right? So it's the first agent to be administered. And as an anticoagulant given on those patients, heparin can inhibit, aside from thrombin, it can inhibit factor 12, factor 11, factor 9, factor 10, even factor 2. So hindi lang siya basta kay thrombin. Pag sinaksak yan sa pasyente, it's administered intravenously, by the way. Pag sinaksak yan, automatic, it will inhibit those mentioned factors. Again, 12, 11, 10, 9, and factor 2 will be inhibited. The problem with heparin is that medyo mabilis yung half-life niya. Half-life of heparin is about 1 to 2 hours. So say for example, sinaksakan ka ngayon ng heparin ng 1,000 units right now. After 1 hour or 2 hours, bababa na siya by 50%. 500 units na lang matitira. Patagal ng patagal, pababa ng pababa. Kaya, in this case, roughly every 4 hours or every 6 hours, sasaksakan kanila ng heparin to make sure na you can then prevent forming a clot. Okay? And one side effect of heparin administration also is that it can decrease your platelets. Kaya from time to time, you need to monitor your patients. O question, what is that coagulation test that monitors individuals taking heparin? APTT. Right? Then, after heparin, let's say, pinauwi ka na ng bahay, tapos ka na kasing mag-heparin. After heparin, pag pinauwi ka na, you may then have a transition to oral anticoagulants. From heparin, ilalagay ka na sa oral anticoagulant. Kasi at home, you can take this drug. Orally lang naman yan administered. Right? So, the action of oral anticoagulants like coumarin, yung mga warfarin natin or dicumarol is to alter your vitamin K dependent clotting factors. So parang it inhibits vitamin K dependent clotting factors. So you do not form clots. And to monitor them, what's the test? To monitor individuals under oral anticoagulant therapy,
PT.
prothrombin time. Okay, and then lastly, you can go with antiplatelet drugs like aspirin by inhibiting cyclooxygenase, right? So you don't form thromboxane A2, so you can prevent the formation of clot. Kaya yung mga, yung may mga sakit sa puso, inatake na sa puso, di ba, yung iba sa kanila nagtitake ng aspirin. Parang you call them generally as blood thinners, pampalabnaw ng dugo. So you can then avoid the formation of unwanted clots. And other drugs that may be administered to prevent clotting would include the following. Yan, actually yun yung mga side effect nila. Hindi siya directly for clotting, but that would be the side effects of those drugs. NSAIDs, antibiotics, that would be the side effect. Okay, para mapigilan mo yung pag-form ng clots. Okay? So to sum it up, when it comes to hemostatic disorders, remember, if you have problems with platelets, vessels, clotting factors, plasminogen, plasmin, again, in hemostatic disorders, it's either your patient end up with bleeding or with thrombosis. That's the most significant thing. Okay? So you need to find out what causes the bleeding or what causes the thrombosis. That's why you need to go over always with laboratory tests. Okay? Sige, with that, do you have any questions or clarifications? Sige, kung wala, yung quiz ninyo for blood vessels, I will open it at 9:15 a.m. today. Okay? 9:15, i-open ko yung blood vessel disorder quiz ninyo. And then, meet na lang tayo siguro mga 9:45 sa laboratory. Okay? And the next one, I will be asking you to make your OBE diary. Sa lecture, iba yung lecture, iba yung lab. Just like with your other courses, other subjects, I'll be asking you to create your OBE diary, giving your reflections in all the topics that we've had starting nung prelim. Okay? Here's the thing. I will group you in Canvas, and every member of the group will write his or her own reflection. Every member. Ang gagawin lang ni group leader is to compile the reflections of the members and submit it in Canvas as one. Para yung file, isa lang. And then dun sa isang file na yon, lahat na ng reflections ng mga members ng group. So I will group you randomly in Canvas, and I will let Canvas choose the leader for you. Again, every member will write his or her own reflection, and the group leader is the one to compile all reflections of the members. Okay? Para ang isa-submit is isang file lang. Isa lang yung marireceive ko. Para pag binasa ko, isang file lang, hindi na ako bukas ng marami. Lagyan nyo lang ng pangalan yung mga reflections. In all topics, starting yung prelim. Is that clear?
Yes po, sir.
Yes
So
po.
that is to be submitted next year. Okay? January. Hintayin nyo na lang sa Canvas kung ano yung deadline. Pero as early as now, you can now make your own. Okay? So sige, you may have your break, and then yung quiz nyo is na lang 9:15 with blood vessel disorders. Okay? Sige, so kung wala na kayong tanong, you are free to leave the meeting room. Thank you.
Thank you, sir.
Yes, sir.
Sige.